Diseases of Ear, Nose and Throat and Head and Neck Surgery by P.L. Dhingra. Chapter 4, Assessment of Hearing. Hearing loss can be of three types. Conductive hearing loss. It is caused by any disease process interfering with the conduction of sound from the external ear to the stapediovestibular joint. Thus, the cause may lie in the external ear, obstructions, tympanic membrane, perforation, middle ear, fluid, ossicles, fixation or disruption, or the estriation tube obstruction. Sensorineural hearing loss. It results from lesions of the cochlea, sensory type, or cranial nerve 8, or and its central connections, neural type. The term retrocochlear is used when hearing loss is due to lesions of eighth nerve and central deafness, when it is due to lesions of central auditory connections. Mixed hearing loss. In this type, elements of both conductive and sensorineural deafness are present in the same ear. There is air-bone gap indicating conductive element and impairment of bone conduction BC indicating sensorineural loss. Mixed hearing loss is seen in some cases of otosclerosis and chronic suppurative otitis media. While assessing the auditory functions, it is important to find out type of hearing loss, conductive, sensorineural or mixed, degree of hearing loss, mild, moderate, moderately severe, severe, profound or total. Site of lesion, if conductive, the lesion may be at external ear, tympanic membrane, middle ear, ossicles or estriation tube. Clinical examination and tympanometry can be helpful to find the site of such lesions. If sensorineural, find out whether the lesion is cochlear, retrocochlear, or central. Special tests of hearing will be required to differentiate these types. Cause of hearing loss. The cause may be congenital, traumatic, infective, neoplastic, degenerative, metabolic, autotoxic, vascular, or autoimmune process. Detailed history and laboratory investigations are required. Assessment of hearing. Hearing of an individual can be tested by clinical and audiometric tests. Clinical tests of hearing. Finger friction test, watch test, speech tests, tuning fork tests. Finger friction test. It is a rough but quick method of screening and consists of rubbing or snapping the thumb and a finger close to the patient's ear. Watch test. A click watch is brought close to the ear and distance at which it is heard is measured. It had been popular as a screening test before audiometric era but is practically obsolete now. Clicking watches are also obsolete. Speech voice tests. Normally a person hears conversational voice at 12 meter 40 feet and whisper with residual air after normal expression at 6 meter that is 20 feet. But for purposes of test 6 meter is taken as normal for both conversation and whisper. The test is conducted in reasonably quiet surroundings. The patient stands with his ear towards the examiner at a distance of 6 meter. His eyes are shielded to prevent lip reading and the non-test ear is blocked by intermittent pressure on the tragus by an assistant. The examiner uses spondy words, example, black, night, football, daydream, or numbers with letters X3B, 2AZ, M6D, and gradually walks towards the patient. The distance at which the conventional voice and whispered voice are heard is measured. The disadvantage of speech tests is lack of standardization in intensity and pitch of voice used in tests and the ambient noise of the testing place. Tuning fork tests. These tests are performed with tuning forks of different frequencies such as 128, 256, 512, 1024, 2048, and 4096 Hz. But for routine clinical practice, tuning forks of 512 Hz is ideal. Forks of lower frequencies produce sense of bone vibration while those of higher frequencies have shorter decay time and are thus not routinely preferred. A tuning fork is activated by striking it gently against the examiner's elbow, heel of hand, or rubber heel of the shoe. To test air conduction, a vibrating fork is placed vertically in line with the meatus, about 2 cm away from the opening of external auditory canal. The sound waves are transmitted through the tympanic membrane, middle ear, and ossicles to the inner ear. Thus, by air conduction test, the function of both the conducting mechanism and the cochlea are tested. Normally, hearing through air conduction is louder and heard twice as long as through the bone conduction route. To test bone conduction, the foot plate of vibrating tuning fork is placed firmly on the mastoid bone. Cochlea is stimulated by vibrations conducted through the skull bones. Thus, bone conduction is a measure of the cochlear function only. Clinically useful tuning fork tests include Rene's. In this test, air conduction of the ear is compared to its bone conduction. A vibrating tuning fork is placed on the patient's mastoid, and when he stops hearing, it is brought beside the meatus. If he still hears, air conduction is more than bone conduction. Alternatively, the patient is asked to compare the loudness of sound heard through air and bone conduction. Rene's is also called positive when air conduction is longer or louder than bone conduction. It is seen in normal persons or those having sensory neural deafness. A negative Rene, bone conduction more than air conduction, is seen in conductive deafness. A negative Rene indicates a minimum airborne gap of 15 to 20 decibel. A prediction of airborne gap can be made if tuning forks of 256, 512, and 1024 Hz are being used. A Rene's test equal or negative for 256 Hz but positive for 512 Hz indicates airborne gap of 20 to 30 decibel. A Rene's test negative for 256 and 512 Hz but positive for 1024 Hz indicates airborne gap of 30 to 45 decibel. A Rene's negative for all three tuning forks of 256, 512, and 1024 Hz indicates a airborne gap of 45 to 60 decibel. Remember that negative Rene for 256, 512, and 1024 Hz indicates a minimum airborne gap of 15 to 30, 45 decibel respectively. False negative Rene. It is seen in severe unilateral sensory neural hearing loss. The patient does not perceive any sound of tuning fork by air conduction but responds to bone conduction testing. This response to bone conduction is in reality from the opposite ear because of transcranial transmission of sound. In such cases, correct diagnosis can be made by masking the non-test ear with Burney's noise box while testing for bone conduction. Weber test will further help as it gets localized to the better ear. Weber test. In this test, a vibrating tuning fork is placed in the middle of the forehead or the vertex, and the patient is asked in which ear the sound is heard. Normally, it is heard equally on in both ears. It is lateralized to the worse ear in conductive deafness and to the better ear in sensory neural deafness. In Weber's test, sound travels directly to the cochlea via bone. Lateralization of sound in Weber's test with a tuning fork of 512 Hz implies a conductive loss of 15 to 25 decibel in ipsilateral ear or a sensory neural loss in the contralateral ear. Absolute bone conduction test. Bone conduction is a measure of cochlear function. In absolute bone conduction ABC test, the patient's bone conduction is compared to that of the examiner's, presuming that the examiner has normal hearing. External auditory meatus of both the patient and examiner should be occluded by pressing the tragus inwards to prevent ambient noise entering through air conduction route. In conductive deafness, the patient and examiner hear the folk for the same duration of time. In sensorineural deafness, the patient hears the folk for a shorter duration. Schwabach's test. Here, again, bone conduction of the patient is compared to that of the normal hearing person. Examiner, but not occluded. It has the same significance as airborne conduction test. Schwabach's test is reduced in sensorineural deafness and lengthened in conductive deafness. Bing test. It is a test of bone conduction and examines the effect of occlusion of ear canal on the hearing. A vibrating tuning fork is placed on the mastoid while the examiner alternatively closes and opens the ear canal by pressing on the tragus inwards. A normal person or one with sensorineural hearing loss hears louder when ear canal is occluded and softer when the canal is open, being positive. A patient with conductive deafness will appreciate no change, being negative. Gillies test. It is also a test of bone conduction and examines the effect of increased air pressure in ear canal on the hearing. Normally, when the air pressure is increased in the ear canal by Siegel's speculum, it pushes the tympanic membrane and ossicles inwards, raises the intralabyrinthine pressure and causes immobility of basilar membrane and decreased hearing. But no change in hearing is observed when ossicular chain is fixed or disconnected. Gillies test is performed by placing a vibrating fork on the mastoid while changes in air pressure in the ear canal are brought by Siegel's speculum. Gillies test is positive in normal persons and in those with sensorineural hearing loss. It is negative when ossicular chain is fixed or disconnected. It was a popular test to find out stapes fixation on autosclerosis, but has now been superseded by tympanometry. Tuning fork tests. Test for air conduction. A. B. Testing for bone conduction. C. Weber's test. Tuning fork test and their interpretation. Test Rene's test normal air conduction more than bone conduction, Rene positive. Conductive deafness, bone conduction is more than air conduction in Rene's negative. Sensory neural deafness, air conduction is more than bone conduction. Weber's test normal, not lateralized. Conductive deafness, lateralized to poorer ear. Sensory neural deafness, lateralized to better ear. Airborne conduction, same as examiners. Conductive deafness, same as examiners. Sensory neural deafness, reduced. Schwabach's test, normal, equal on both sides. Conductive deafness, lengthened. Sensory neural deafness, shortened. Two-room audiometry setup. Audiometrician watches the response of patients sitting across a glass partition. Audiometric tests. 1. Pure tone audiometry. An audiometer is an electronic device which produces pure tones, the intensity of which can be increased or decreased in 5 decibel steps. Usually, air conditioned thresholds are measured for tones of 125, 250, 500, 1000, 2000, 4000, and 8000 Hz, and both conduction threshold for 250, 500, 1000, 2000, and 4000 Hz. The amount of intensity that has to be raised above the normal level is a measure of the degree of hearing impairment at that frequency. It is charted in the form of a graph called audiogram. The threshold of bone conduction is a measure of cochlear function. The difference in the thresholds of air conduction and bone conduction, that is AB gap, is a measure of the degree of conductive deafness. It may be noted That audiometer is so calibrated that the hearing of a normal person, both for air conduction and both conduction, is at 0 decibel and there is no airborne gap, while tuning fork test normally shows air conduction more than bone conduction. When differentiated between the two ears is difference between the two ears is 40 decibel or above in air conduction threshold, the better ear is masked to avoid getting a shadow curve from the non-test better ear. Similarly, masking is essential in all bone conduction studies. Masking is done by employing narrow band noise to the non-test ear. Uses of pure tone audiogram. It is a measure of threshold of hearing by air and bone conduction and thus the degree and type of hearing loss. A record can be kept for future reference. Audiogram is essential for prescribing hearing aid. Helps to find degree of handicap for medical legal purposes. Helps to predict speech reception threshold. Speech audiometry. In this test, the patient's ability to hear and understand speech is measured. Two parameters are studied: speech reception threshold and discrimination score. SRT or speech reception threshold, it is the minimum intensity at which 50% of the words are repeated correctly by the patient. A set of spondy words, two syllable words with equal stress on each syllable. Example: baseball, sunlight, daydream, etc. is delivered each to each ear through the headphone of an audiometer. The words lists are delivered in the form of recorded tapes or monitored voice, and their intensity varied in 5 decibel steps till half of them are correctly heard. Normally, SRT or speech reception threshold is within 10 decibels of the average pure tone thresholds of three speech frequencies, that is 500,000 and 2000 hertz, and speech reception threshold better than pure tone or average by more than 10 decibels suggests a function hearing loss. Speech discrimination score. Speech discrimination score is also called speech recognition or word recognition score. It is a measure of the patient's ability to understand speech. Here, a list of phonetically balanced PB words, single syllable words, example, pin, sin, day, bus, etc., is delivered to the patient's ear separately at 30 to 40 decibel above his or her speech reception threshold, and the percentage of words correctly heard by the patient is recorded. In normal persons and those with conductive hearing loss, a high score of 90 to 100 percentage can be obtained. Performance intensity function for phonetically balanced words. PB max. Instead of using single supra threshold intensity of 30 to 40 decibel above speech reception threshold as described above, it is better to chart the PB scores against several levels of speech intensity and find the maximum score, PB max, a person can attain. Also, note the intensity of sound at which the PB max is attained. It is a useful test clinically to set the volume of hearing aid. Maximum volume of hearing aid should not be set above PB max. Rollover phenomenon. It is seen in retrocochlear hearing loss with increase in speech intensity above a particular level. The PB word score falls rather than maintaining a plateau as in cochlear type of sensorineural hearing loss. Thus, speech audiometry is useful in several ways. To find SRT, which correlates well with an average of three speech frequencies of pure tone audiogram. To differentiate organic from non organic functional hearing loss. To find the intensity at which discrimination score is the best. This is helpful for fitting a hearing aid and setting its volume for maximum discrimination. To differentiate a cochlea from retrocochlear sensorineural hearing loss. Score percentage 20, 0, 20, 40, 60, 80, 100. Amplification in decibel 10, 20, 30, 40, 50, 60, 70, 80, 90, 100. A curve normal, B curve showing conductive hearing loss. Speech audiogram, score percentage and amplification in decibel, curve C and curve D. Curve C showing sensorineural hearing loss. Ability to understand speech and its relation to speech discrimination score. A list of 50 PB words is presented and the number correctly heard is multiplied by 2. 90 to 100 percentage normal, 76 to 88 percentage slightly difficult, 60 to 74 percentage moderately difficult, 40 to 58 percentage poor, less than 40 percentage very poor. Rollover phenomenon, it is seen in retrocochlear hearing loss with increase in speech intensity above a particular level. The PB word score falls rather than maintaining a plateau as in cochlear type of sensory neural hearing loss. Thus, speech audiometry is useful in several ways to find the speech reception threshold, which correlates well with an average of three speech frequencies of pure tone audiogram to differentiate organic from non organic functional hearing loss to find the intensity at which the discrimination score is the best. This is helpful for fitting a hearing aid and setting its volume for maximum discrimination to differentiate a cochlear from retrocochlear sensory neural hearing loss. Bekasi audiometry. It is a self recording audiometry where various pure tone frequencies automatically move from low to high while the patient controls the intensity through a button. Two tracings, one with continuous and the other with pulsed tone, are obtained. The tracing helps to differentiate a cochlear from retrocochlear and an organic from a functional hearing loss. Various types of tracing are obtained: type 1, type 2, type 3, type 4, and type 5. Type 1 continuous and pulsed tracing overlap seen in normal hearing or conductive hearing losses. Type 2 continuous and pulsed tracing overlap up to 1000 Hz and then continuously tracing falls seen in cochlear loss. Type 3 continuous tracing falls below pulse tracing at 100 to 500 Hz, even up to 40 to 50 decibel seen in retrocochlear or neural lesions. Type 4 continuous tracing falls below pulsed lesion at frequencies up to 1000 Hz by more than 25 decibel seen in retrocochlear or neural lesion. Type 5 continuous tracing is above pulsed 1 seen in non-organic hearing loss. Bekasi audiometry is seldom performed these days. Impedance audiometry. It is an objective test widely used in clinical practice and is useful in children. It consists of tympanometry and autoacoustic reflex measurements. Tympanometry, it is based on a simple principle, that is, a sound strikes tympanic membrane, some of sound energy is absorbed while the rest is reflected. A stiffer tympanic membrane would reflect more of sound energy than a compliant one. By changing the pressures in a sealed external auditory canal and then measuring the reflected sound energy, it is possible to find compliance or stiffness of the tympano-ossicular system and thus find the healthy or diseased status of the middle ear. Essentially, the equipment consists of a probe which snugly fits into the external auditory canal and has three channels: one to deliver a tone of 220 Hz, two to pick up the reflected sound through a microphone, and three to bring about changes in the air pressure in the ear canal from positive to normal and then negative. By charting the compliance of tympano-ossicular system against various pressure changes, different types of graphs called tympanograms are obtained, which are diagnostic of certain middle ear pathologies. This is tympanoaudiometry in progress and impedance audiometer. Impedance audiometer. Principles of impedance audiometer. A. Oscillator to produce a tone of 220 Hz. B. Air pump to increase or decrease the air pressure in the ear canal. C. Microphone to pick up and measure sound pressure level reflected from the tympanic membrane. Types of tympanograms. Type A, normal tympanogram. Type AS, compliance is lower at or near ambient air pressure seen in fixation of oxicles, example autosclerosis or malleus fixation. AS. Type AD, high compliance or near ambient pressure seen in ossicular discontinuity or thin and lax tympanic membrane. AD. Type B, a flat or dome shaped graph, no change in compliance when pressure changes, seen in middle ear fluid or thick tympanic membrane. Type C, maximum compliance occurs with negative pressure in excess of 100 mm H2O, seen in retracted tympanic membrane and may show some fluid level in middle ear. Type C. Types of tympanograms, compliance and A curve, AS curve, AD curve, B curve, C curve. Testing of eustachian tube. Tympanometry has also been used to find function of eustachian tube in cases of intact or perforated tympanic membrane. A negative or a positive pressure minus 200 or plus 200 mm H2O is created in the middle ear and the person is asked to swallow 5 times in 20 seconds. The ability to equilibrate the pressure indicates normal tubal function. The test can be used to find patency of the grommet placed in the tympanic membrane in cases of serious otitis media. Acoustic reflex. It is based on the fact that a loud sound 70 to 100 decibel above the threshold of hearing of a particular ear causes bilateral contraction of the stapedial muscles, which can be detected by tympanometry. Tone can be delivered to one ear and the reflex picked from the same or the contralateral ear. The reflex arc involved is as follows: ipsilateral cranial nerve 8, ventral cochlear nucleus, cranial nerve 7, nucleus, ipsilateral stapedial muscle, contralateral cranial nerve 8, ventral cochlear nucleus, contralateral medial superior olivary nucleus, contralateral cranial nerve 7 nucleus, contralateral stapedial muscle. This test is useful in several ways. To test the hearing in infants and young children is an objective method. To find malingers, a person who feigns total deafness and does not give any response on pure tone audiometry but shows a positive stapedial reflex is a malingerer. To detect cochlear pathology, presence of stapedial reflex at lower intensities, example 40 to 60 decibel than the usual 70 decibel indicates recruitment and thus a cochlear type of hearing loss. To detect eighth nerve lesion, if a sustained tone of 500 to 1000 Hz delivered at 10 decibel above the acoustic reflex threshold for a period of 10 seconds brings the reflex amplitude to 50%. It shows abnormal adaptation and is indicative of cranial nerve 8 nerve lesion, stapedial reflex decay. This is the acoustic reflex shown in figure 4.7. We have the cranial nerve 8, superior olivary complex, cranial nerve 7. Lesions of facial nerve, absence of stapedial reflex when hearing is normal indicates lesion of facial nerve proximal to the nerve or to stapedius. The reflex can also be used to find prognosis of facial paralysis as the appearance of reflex after it was absent, indicate return of function and favorable prognosis. Lesion of brainstem. If ipsilateral reflex is present but the contralateral reflex is absent, lesion is in the area of crossed pathways in the brainstem. Physical volume of ear canal. Acoustic emittance can also measure physical volume of air between the probe tip and the tympanic membrane. Normally, it is up to 1 ml in children and 2 ml in adults. Any increase in the volume more than 2 ml in children and more than 2.5 ml in adults indicate perforation of the tympanic membrane because middle ear volume is added to the volume of external ear canal. This has also been used to find patency of the ventilation tube. Special tests of hearing. Recruitment. It is a phenomenon of abnormal growth of loudness. The ear, which does not hear low intensity sound, begins to hear greater intensity sounds as loud as or even louder than normal hearing. Thus, a loud sound which is tolerable in normal ear may grow to abnormal levels of loudness in the recruiting ear and thus becomes intolerable. The patient with recruitment are poor candidates for hearing aids. Recruitment is typically seen in lesions of the cochlea, example Meniere's disease and presbycusis, and thus helps to differentiate a cochlea from retrocochlea, a sensorineural hearing loss. Alternate binaural loudness balance test is used to detect recruitment in unilateral test cases. A tone, say of 1000 Hz, is played alternatingly to the normal and to the affected ear, and the intensity is affected in the affected ear is adjusted to match the loudness in the normal ear. The test is started at 20 decibel above the threshold of deaf ear and then repeated at every 20 decibel rise until the loudness is matched or the limits of audiometer reached. In conductive and neural deafness, the initial difference is maintained throughout, while in cochlear lesion, partial or complete or over recruitment may be seen. Short increment sensitivity index SISI test. Patients with cochlear lesion distinguish smaller changes in intensity of pure tone better than normal persons, and those with conductive or retrocochlear pathology. SISI test is thus used to differentiate a cochlea from retrocochlear lesion. In this test, a continuous tone is presented 20 decibel above the threshold and sustained for about 2 minutes every 5 seconds. The tone is increased by 1 decibel and 20 such blips the, are presented. The patient indicates the blips heard. In conductive ear deafness, SISI score is seldom more than 15%. It is 70 to 100% in cochlear deafness and 0 to 20% in nerve deafness. Threshold tone decay test. It is a measure of nerve fatigue and is used to detect retrocochlear nerve lesions. Normally, a person can hear a tone continuously for 60 seconds. In nerve fatigue, he stops hearing earlier. The threshold tone decay test is simple and is performed in the following manner. A tone of 4000 Hz is presented at 5 decibel above the patient's threshold of hearing continuously for a period of 60 seconds. If the person stops hearing earlier, intensity increases by another 5 decibel. The procedure is continued till the patient can hear the tone continuously for 60 seconds or no level excess above the threshold tone audible for full 60 seconds. The result is expressed as the number of decibels of decay. A decay more than 25 decibel is diagnostic of a retrocochlear lesion. Alternate binaural loudness balance test. 0 to 90, 0 to 90, right and left. 0 to 90, 0 to 90. Electrocochleography: A. Normal ear. B. Ear with the Meniere's disease. Voltage of summating potential is compared to that of the action potential. Normal summating potential is 30% of action potential. This ratio is enhanced in Meniere's disease. So we can see the A and B. A is microvolts and milliseconds. Stimulus, summating potential, action potential, and baseline. Here we have microvolts, milliseconds, stimulus, summating potential, and action potential. Evoked response audiometry. It is an objective test which measures electrical activity in the auditory pathways in response to auditory stimuli. It requires special equipment with an averaging computer. There are several components of evoked electrical response, and only have gained clinical acceptance. They are as follows: electrocochleography, echo G. It measures the electrical potentials arising in the cochlea and cranial nerve 8 in response to auditory stimuli within first 5 milliseconds. The response is in the form of three phenomena: cochlear microphonics, summating potentials, and the action potential of cranial nerve 8. The recording electrode is usually a thin needle passed through the tympanic membrane onto the promontory. In adults, it can be done under local anesthesia, but in children or anxious patients, sedation or general anesthesia is required. Sedation does not interfere in these responses. ECOG is useful. 1. To find the threshold of hearing in young infants and children within 5 to 10 decibel. 2. To differentiate lesions of cochlea from those of cranial nerve 8. Auditory brainstem response, ABR, also called BAER or BAEP. Brainstem auditory evoked response or potential, or BERA. BERA, brainstem evoked response audiometry, is to elicit brainstem response to auditory stimulation by clicks or tone bursts. It is a non invasive technique to find the integrity of central auditory pathways through the eighth nerve, pons, and midbrain. In this method, electrical potentials are generated in response to several click stimuli or tone bursts and picked up from the vertex by surface electrodes. It measures hearing sensitivity in the range of 1000 to 4000 Hz. In a normal person, 7 waves are produced in the first 10 millisecond. The first, third, and fifth waves are most stable and used in measurements. The waves are studied for absolute latency, interwave latency, usually between wave 1 and 5, and the amplitude. The exact anatomic site of neural generations for various waves is disputed, but the latest studies indicate the following sites: wave 1, distal part of cranial nerve 8; wave 2, proximal part of cranial nerve 8 near the brainstem; wave 3, cochlear nucleus; wave 4, superior olivary complex; wave 5, lateral lemniscus; and wave 6 and 7, inferior colliculus. Brainstem auditory evoked potentials. Wave 1 to 3, 2 millisecond. Wave 4 to 3 to 4, 5, 2 millisecond. Wave 1 to 5, 4 millisecond. As an aid memory, remember the mnemonic E coli 8 8, cochlear nucleus, olivary complex, lateral lemniscus, inferior colliculus. Compare E. colima Eighth nerve, cochlear nucleus, olivary complex, lateral lemniscus, inferior colliculus, medial geniculate body, auditory cortex in pathways of hearing. ABR is used as screening for procedure for infants. 2. To determine the threshold of hearing in infants, also in children and adults who do not cooperate, and in malingerers. 3. To diagnose retrocochlear pathology, particularly acoustic neuroma. 4. To diagnose brainstem pathology, example, multiple sclerosis or pontine tumors. 5. To monitor cranial nerve 8 intraoperatively in surgery of acoustic neuromas to preserve the function of cochlear nerve. Auditory steady state response through ABR conducted with tone bursts of various frequencies can produce frequency specific thresholds of hearing in infants to fit hearing aid at a young age. It has limitations. It cannot test hearing losses above 80 decibel. It cannot detect hearing sensitivity in severe to profoundly deaf infants. Auditory steady state response ASSR is useful in such situations. It is like ABR, an electrophysiological test which uses steady state pure tone signals instead of transient signals of tone bursts or clicks used in ABR. The steady state signals are also modulated rapidly in amplitude and frequency and thus give a frequency specific audiogram. Hearing losses exceeding 80 decibel can be detected. It can help in the selection of children for cochlear implantation at an early age. Autoacoustic emissions. They are low intensity sounds produced by outer hair cells of normal cochlea and can be elicited by a very sensitive microphone placed in the external ear canal and analyzed by a computer. Sound produced by outer hair cells travels in a reverse direction. Outer hair cells, basilar membrane, perilymph, oval window, ossicles, tympanic membrane, ear canal, autoacoustic emissions are present when outer hair cells are healthy and are absent when they are damaged and thus help to test the function of cochlea. They do not disappear in eighth nerve pathology as cochlear hair cells are normal. Types of OAEs. Broadly, OAEs are of two types, spontaneous and evoked. The latter are elicited by a sound stimulus. Spontaneous OAEs, they are presently in healthy, normal hearing persons where hearing loss does not exceed 30 decibel. They may be absent in 50% of normal persons. Evoked OAEs. They are further divided into two types depending on the sound stimulus used to elicit them. Transient evoked OAEs, evoked by clicks. A series of click stimuli are presented at 80 to 85 decibel sound pressure level and response recorded. Product OAEs, two tones are simultaneously presented to the cochlea to produce distortion production products. They have been used to test hearing in the range of 1000 to 8000 Hz. Uses. OAEs are used as screening tests of hearing in neonates and to test hearing in uncooperative or mentally challenged individuals after sedation. Sedation does not interfere with OAEs as they help in distinguish cochlear from retrocochlear hearing loss. OAEs are absent in cochlear lesions. Example, autotoxic sensorineural hearing loss. They detect autotoxic effects earlier than pure tone audiometry. OAEs are useful to diagnose retrocochlear pathology, especially auditory neuropathy. Auditory neuropathy is a neurological disorder of cranial nerve 8. The audiometric test example, sensorineural hearing loss for pure tones, impaired speech discrimination score, absent on abnormal ABR, show retrocochlear type of lesion, but OAEs are normal. OAEs are absent in 50% of normal individuals, lesions of cochlear, middle ear disorders, as sound travels in reverse direction cannot be picked up, and when hearing loss exceeds 30 decibel. Central auditory tests. Patients with central auditory disorders have difficulty in hearing in noisy surroundings or when speech is distorted and not clearly spoken. Three different types of speech discrimination tests are used. Monotonic test. It is presented with speech message which is distorted. Patients with lesions of brain and cortex have difficulty to understand the message. B. Dichotic test. Two different speech messages are presented simultaneously, one to each ear, and the patient is asked to identify both. Staggered spontaneic words test is the one more often used. Pairs of spontaneic words along with digits or nonsense words are simultaneously presented to the ear. Patient with temporal lobe lesions will have difficulty identifying these words when presented to the ear opposite to that of the side of the lesion. C. Binaural tests. They are used to identify integration of information from both ears. Such tests are normal in cortical lesions but effect in lesions of brainstem and thus help to localize the site of lesion. The most common tests used in binaural masking level difference test. Central auditory tests are not used routinely. Hearing assessment in infants and children, see page 138.